us off. Thank you everyone for joining. I'm going to introduce Dr. Adam Leventhal, the director of the USC Institute for Addiction Science.
Hi, everyone. Thank you for joining our second COVID-19 research roundtable on social and behavioral sciences and mental and behavioral health. So we had a really great session last month, and there was so much interest that there was a request to do it again this month. And really glad to also have a co-sponsor in the USC Center for Changing Family, which you'll hear about, along with our Institute of Addiction Science, the Keck School of Medicine, and CHLA. So next slide. Okay. So welcome everyone, and I think Dr. Unger is here too, the co-chair for our research task force on social behavioral sciences and related to COVID. So we have a really exciting list of speakers, and just as last time, you know, the goal of today is for folks to learn about the various types of research projects that are either ongoing or maybe in preparation across the entire university and the hospital system related to COVID-19, and also to potentially identify people you might want to collaborate with, learn from, get a resource from, a measure from, and whatnot. So, you know, the goals of this are very broad. We have, how many do we have? 7 speakers today? 7 or 8?
Well, 9. Very
9.
exciting. Yes.
9. So this will be like rapid fire, or what, I forget what the term is for this now, where you get these fast presentations, but they'll be quick and to the point, and then there'll be a time at the end for a roundtable discussion where the various attendees can ask the presenters, the whole entire panel, questions either related to their project or stuff that's cross-cutting. So is there any other housekeeping stuff, Kristen?
Yeah, so for the roundtable discussion, I will keep an eye on both the chat and the Q&A function. If you haven't done a webinar before, there's a Q&A function at the bottom of your screen, or the ribbon for your Zoom account. Please use that and the chat. And if you want to ask a question live, you're welcome to do that by raising your virtual hand, and we'll get to it at the end. You can also ask questions anonymously. So yes, looking forward to that portion of the meeting.
Okay. Next slide. This is kind of like a joint effort, and so this involves these, you know, the Center for Changing Family, our institute, and also there's the Keck School of Medicine. There's a research task force that's dedicated to stimulating new research projects, you know, across the healthcare system and also, you know, across USC wide. And there's a special affinity group that's devoted to social and behavioral sciences and mental health. And so that also plays a role in this. And Dr. Unger, who co-chairs that with me. So I think next slide. And then just a little background, shameless plug, we're the USC Institute for Addiction Science. We got members from 8 schools, 63 faculty, you know, and the goal for us is we're really trying to simulate new transdisciplinary research and educational programs on the topic of addiction. And of course, here, this is a topic that's much broader than addiction. Addiction is a key component of the potential impact of the pandemic on public health and well-being. But of course, there are many other aspects which will be covered today by our speakers. But for those folks who are interested, please visit our website. If you want to learn more, you want to join as a member, we have a trainee network. And also we have a new minor that's will be going online this fall, a minor in addiction science that's cross-cutting. And so definitely, if you have undergraduate students who are interested in this topic, give a plug to us. And you know, all this is underpinned by Dr. Kristen Dahlquist, our amazing Director of Operations. So I'd also like to introduce Dr. Darby Saxby, who is the director of this new exciting Center for the Changing Family, who is co-sponsoring this with us. And so with that, I'll turn it over to you, Darby.
Right. Thank you so much. And thank you for inviting us to help coordinate this event. This is a really exciting opportunity for us to share our new center. So we are quite new. We started in last spring in response to a USC Dornsife College solicitation for faculty-led initiatives. So we started as a faculty working group looking at family stress and health, and then we applied and were selected for full funding to establish the group as a center just in January of this year. Next bullet. So our goal is to connect researchers across departments, across campuses who are interested in families. That includes people who study parent-child relationships, couples, family caregiving with older adults, family law, and family therapy. Next bullet. And so our members range from clinical psychology, sociology, economics, law, a number of people from the medical school, including pediatrics, preventive medicine. Next bullet. And our goals are to collaborate to really sort of be a center for research that involves the family. We're hoping to put together a training grant to introduce a new minor. I wish I had a cool infographic like Adam just showed, but maybe that's something we can create as well. And we've just recently awarded 14 small grants for projects related to COVID-19 and the family. So I'm excited that 4 of our grantees will be presenting today. And last bullet. Oh, and I forgot to mention social work is another one of the schools that we have members from. And if you are interested in, if you're conducting research on families or you work with families in some capacity, we're very open to new members. Please feel free to check out our website or reach out to me if you're interested in affiliating with the center. Thanks.
Thank you, Dr. Saxby. I'm going to review really quick what you'll find in a Google Drive that we've put together after our first roundtable session. There's a lot of funding available both through the government, through USC, and through external private funding. And we have all of those listed in this drive that I'll send you via email. One new one since our last roundtable is through the Keck School of Medicine. There was a gift from William Keck, and you can apply for that for rapid funding now. And it is first come, first serve, so there is benefit to applying sooner rather than later. We also compiled a list of research and data resources for you that will be found in the Google Drive, from available data to research measures, where to find those, and a curation of COVID-19 literature. There's one event I wanted to share with you that was shared with me. It is on Friday at the same time. There is 4 speakers, more on the medicine side of COVID research, but it should be incredibly interesting if you have interest in that. It is free to join, and the RSVP link will also be shared with you after this meeting.
And Kristen, just really quickly, like 2 more points before we get in. So about the new Keck RFA, first come, first serve, those people who are not faculty in Keck can apply, but they must apply in tandem with a faculty member in Keck. And so that's just one thing I want to mention. And so that's why we do these types of roundtables too, so we can kind of do a matching thing where folks across schools can get together. I forgot to mention our major funders, who are on the line, the Treitler family for our Institute for Addiction Science, so we're grateful to them. And also, maybe before we swing into this, to the speakers, is Jennifer still on the line? If she wanted to, Jennifer, yeah, there you are. Hey Jen, do you wanna do like a quick overview on the hospital, the care workers cohort?
Yeah, I can give an update. We've made a little bit of progress. We're hoping to enroll up to 7,000 Keck healthcare workers to get tested periodically and report their symptoms periodically. And then in a few months, they'll report their mental health and lifestyle and emotional effects of COVID. And it's still very much in the planning stages and the stage of determining who's in charge of what. But I'm confident that those things will be ironed out and it will happen sometime soon.
Awesome, thanks. Yeah, so be on the lookout for that, and we'll continue to update you as that exciting study launches. And the idea is that it'll be a shared resource for all sorts of researchers interested in COVID. So thanks, Jen.
Thank you, Adam. We also have a long list of all of the submitted projects or ideas for research projects with the individual's name and their contact information. So reviewing that could be a good way to create collaborations as well after this. Like Adam mentioned before, we have a round robin style presentation today. We have 9 presenters, 3 to 5 minutes per presenter. And then we're going to take the questions at the end, and we're going to start with Dr. Alan Nager.
Great, thanks very much. I appreciate the opportunity. Next. So our study is entitled Evaluation of Psychosocial Stress and Coping During the Coronavirus Pandemic Among Adolescents and Young Adults. Of late, the last bunch of years, my primary research interest has been on mental health related issues, primarily stress and anxiety for patients coming into the emergency department. Next. So based on multiple studies, we know that adolescents and young adults suffer from anxiety, depression, and of course the world is different. There's confinement, loss of family income, social structure changes. This article, which you see, also parallels our interest. This study, for those of you who couldn't see, is called Mental Health Status Among Children in Home Confinement During the Coronavirus Disease in the Hubei province in China. So this is an important topic and one that many of us see as important and worthwhile to investigate and perhaps make changes. Adolescents and young adults, we know, can often lack emotional maturity. They have limited resources. They don't often know where to go for assistance and help. Next. So much of this assessment and survey tool was based on a previously examined topic that we published a few years ago, in which we took patients 12 years and greater who come into the emergency department for medical complaints and screened them for high-risk behaviors, psychosocial issues such as bullying, domestic violence, sexual abuse, bullying, a variety of topics, of which some of the more important results showed that adolescents and young adults can be very depressed, anxious, and at times suicidal. And the emergency department is a perfect place to capture those patients and address their needs. So we felt a certain amount of obligation a number of years ago, since the American Academy of Pediatrics, the Emergency Nursing Association, and the Joint Commission all state very emphatically that the emergency department is the exact environment to assess these kinds of issues early on so that interventions can take place. So based on that previous study and this need and obligation, we created a 12-question screener with yes and no questions. The resident who's involved in this study took her initial stab at developing questions. We then asked for involvement from other physicians, social workers, psychologists, et cetera, to vet the questions back and forth until we came to consensus. Next. So the methodology is essentially quite simple. All patients 12 years or greater entering the ED for medical complaints were identified by their treating ED physician. Folders were created. The survey was put into one folder that said blank surveys, the other that said completed. They were placed at our 4 different zones in the emergency department. Education happened both in person, remotely, and a variety of text messages went out frequently because in the busyness of an emergency department, study enrollment can sometimes be missed. In general, the clinician was educated. While they were caring for the patient, they introduced the topic, they gave them an information sheet. The parents or caregivers were excused out of the room so a confidential screening and discussion could take place. Next. So without going into significant detail, this is ultimately the screener that we created. In general, some of the questions have to do with, have you talked to your parents, friends? Do you feel like you're having symptoms of COVID? Are you scared or concerned you might be getting the infection? Do you feel anxious, stressed, nervous? Do you feel emotionally supported, etc.? And then based on those responses, an assessment was made by the treating clinician whether or not a social worker should be consulted. Next. Social worker was consulted based on a variety of factors. Could be the responses on the survey, could be a patient saying, I want to see someone, could be based on body language. We didn't devise concrete requirements that would suggest that a social worker has to be consulted. It was up to the treating clinician. And the social workers in our environment are the ones we typically call when there are psychosocial issues that need to be addressed. So far, we've completed 480 surveys, so it's midstream. The study will ultimately go on until either COVID-19 subsides or ends as defined by Society, Children's Hospital Los Angeles, or our command center. Next. Thank you very much.
Thank you, Dr. Nager. Great presentation. We are moving along to Dr. Flores. Trying to get him unmuted right now. Dr. Flores, can you, oh, perfect.
Can you hear me now?
Thank you. Yes.
I apologize for that technical challenge.
Don't worry.
Real quick, it's a pleasure to be here. It's an honor to be invited to participate. I participated in last month's roundtable, and I was very impressed by some of the technologies that were being presented, that I wanted to create awareness amongst some of you. Some of you might know who we are. Some of you may already work with us, but I suspect that most of you probably not. I work in the USC Stevens Center for Innovation, and we are the organization at the University of Southern California that, like many other organizations in any other academic research center in the world, is tasked with helping create awareness of how your inventions, your programs can have social and economic impact in the world. So we are a team of 32 working with investigators across the campus to commercialize or take to the marketplace your innovations. If you move to the next slide, please. Our organization is commonly known or in other places as a technology transfer office. And whereas we typically handle and manage inventions like medical inventions, diagnostics, therapeutics, novel lasers or batteries, we also handle inventions like questionnaires, protocols, data that you accumulate in the course of your research, which may be very valuable for collaborations with industry to help a particular subset of the population or to put into clinical practice as well. So I just wanted to share the website, stevens.usc.edu. We have a lot of information. Every year we receive about 350 new inventions from at least one investigator in each invention that we worked on. And the processes that we cover are that intake of your invention. We cover developing patents where patents can be developed. We do copyrights and trademarks as well. And we also manage the process of confidentiality agreements, material transfer agreements, and data agreements. We also have a group that focuses on corporate collaborations, where we try to facilitate those collaborations with industry that could result in further funding for your labs. Just one more slide. I only have 3 slides. Oh, actually, I have one more after this. Just to create awareness, we started in 1971 by an endowment of one of our alum, USC alum, and we were renamed the Stevens Center for Innovation in 2007. We manage all of the university's intellectual property, stemming from $900 million in annual research funding that we do. Just to give you another piece of information, the biggest success commercial story, impactful story, arises from the invention of organic light electrodiodes that was invented in the chemistry department, and that is licensed to a couple of companies. The last slide. I just wanted to tell you about the process. This is a process that starts with us getting to talk to you, understanding your research. We have PhD staff on all different areas, on all different disciplines, from data analytics, life sciences, physical chemistry. I have a PhD in chemistry and biochemistry, and 12 years of industry before I came to do what I do. It's a long process. It takes months to years, but it starts with having a conversation, understanding what your research is, how is it funded, and what is it that you're trying to achieve if you have any goals to impact, society, commercialize a product. So this ladder represents the process. The link that I have at the top, it is where you go to our website and start engaging with us by telling us about your invention. We have a questionnaire that you can fill. I'm going to stop there and we'll take questions later. Thank you.
Thank you so much. I appreciate it. We move on to Dr. Gail Margolin.
Thank you. It's actually Gayla, so thank you. And thanks for including me in this. I'm really excited about this collaboration that includes the USC Center for the Changing Family, and I'm glad that we're collaborating with the Institute for Addiction Science. So the study I'm going to be mentioning very briefly, and I only have 2 slides because this study is still somewhat aspirational. We're still finalizing our procedures, and we're trying to be nimble as we do this with a changing landscape of policies and variabilities across states and counties. The primary point of our study and what we're trying to look at is how COVID-19 affects couples, and then by extension also affects families, but our initial focus is on couples. And our key question is who is at risk. And what we generally do in the Family Studies Center, which I'm PI for, is investigate the paradox of close and intimate relationships. The paradox being how the very same relationships that are sources of strength and support also cause people huge distress. The same relationships that are protective at times are also risky. And to a large extent, our research focuses on the risky side, on destructive types of conflict in couples, and specifically focusing on emotional and physical aggression. But we also focus equally on sources of resilience, how our relationships are going to help us get through very, very difficult times. So our question here is, what has been the impact of COVID? What is the impact as it plays out in time? And as you can see, what we have been doing so far, what we do in general is look at how couples handle stress, looking at conflict resolution strategies, and then also look how relationship characteristics, particularly connectedness and conflict, affect mental and physical health. The way we typically do it is through multimodal assessments involving direct observation of behavior. Couples come into the lab, we videotape them, then we follow them for a day in their normal activities, and now we're extending it to 7 days, and we're collecting vocal recordings and physiology and EMA and sleep. But all of that has been paused because for all the reasons, all of our research is, with human subjects is paused. So instead, we have been pivoting over to look specifically at how couples respond to COVID-19. And this is motivated by 3 things that I'll just mention in brief. But one is, as it's been reported in a number of places, there's been a spike in rates of domestic violence. This was first noted in Europe when the pandemic was in full force there before here. But many of you probably have heard our own mayor talk about the issues related to domestic violence and the shortage of beds for victims of domestic violence. And there's real problems, obviously, when individuals who are sheltering at home for protection, but when that home is actually a risky or dangerous place. And it's exacerbated when people cannot even get privacy to reach out to resources, the difficulty of even calling 911. So partially, our goal is to understand who is at this sort of more dire level of risk. We also, what we're doing now is also motivated, though, for me personally, in the clinical supervision that I do with students who are seeing couples in our on-campus clinic, and which obviously has moved to telehealth, but some important information was cropping up. So in some of our families, for example, where there's a large multi-generational families living together, maybe 10, 12 people in the same household, these were working okay when people could leave the household for work, either a day or night. But the more people are confined at home, the stress level is going way up. And the other thing that we were finding is that while some pre-existing stressors in families are heightened during since the coronavirus, others actually have been diminished. So some of the families that we're seeing, the relaxing of very hectic schedules in some ways has been positive for them. And seeing sort of the stresses, living and being together all day long and seeing work stresses up front makes some couples or some partners much more empathic to each other. But on the other hand, there's some new stressors with couples reporting just the difficulty of going to the grocery store together and one person wanting to get out as quickly as possible while the other person wanting to browse a bit, and how this has led to very huge conflicts between them. So the questions that we are focusing on with a survey study that we're about to launch is, first of all, how COVID-19 stressors in combination with other pre-existing stressors affect couples. Secondly, how the way couples handled their relationship conflicts in the past, their pre-existing patterns either exacerbate or mitigate the COVID-19 impacts. And then third, how individual characteristics moderate the associations between these stresses and couple processes. If I can have the next slide. So just briefly, I'll talk about the methods. As I mentioned, this is all online. It's open to any couple as long as the participants are over age 18 and currently living in a romantic partner. We're hoping to get people across different states, and also talking to some international collaborators about this. And the key variables that we're looking at are relationship constructs, so both COVID sources of disagreement, things such as our two partners disagreeing about the amount of social distancing, about whether they can see other family members, about when they go out, whether they should be wearing masks. So there's a whole new sort of array of topics that are turning out to be very stressful between partners. And these are then layered on top of their non-COVID types of disagreement about parenting, about finances. We have an array of probably 23 different types of disagreements. But then what we're really addressing is how couples handle disagreements, things that they do to escalate conflict, whether they withdraw, whether they, the ways that they argue with one another, whether they try and explain their own position, try and understand the partner. We're talking about different and unique ways of distributing household responsibilities right now. And we're also trying to capture the positive things, like the way that they're showing closeness and affection. The stresses that we're looking at, just to again say, we're looking at COVID-related stresses, health worries, worries about themselves, each other family members, the extent to which they have known and know people now who are ill with COVID, or they have lost family members due to COVID. The huge financial costs of COVID and the way people's financial circumstances have changed from prior to COVID to now, the extent that they are experiencing some severe financial problems right now, interruptions in life plans and dreams, whether it's going to school or things that they were doing work-wise or other things that they were pursuing, starting a new business. And then in addition to the non-COVID stresses, which you can see here, but we assess these regularly in our research. We're looking at contextual variables in addition to things like ethnicity, race, where they're living, but also the density of dwelling, the difference of living in an apartment building where they have to come in contact with communal doorknobs versus and as soon as they walk out their front door, they can't maintain that distance. And then individual characteristics, and this I know overlaps with some of the things that some of you are looking at. We're looking at sleep quality, alcohol and drug use, density of their dwelling. When we do this, we're going to follow up what we hope with a subsample and look more day to day how they're dealing with stresses to capture the actual directional effects between stresses and relationship processes. And if some of you are interested in any of these dimensions, I'd be delighted to talk with you more. Thank you.
Thank you, Dr. Gail Margolin. That was wonderful. We are moving to Dr. Jonathan Lamb and Dr. Sarah Axine.
Hi, everyone, and thank you so much for inviting us to speak to you guys about what has happened to our emergency department in the past 2-3 months. And we have some really exciting data to show you guys. So since like March, beginning of March, we have observed a huge decrease in patient visit volume in the department. It's nearly 50% drop compared to what happened in February. So next, thank you. So some background here. Our hospital, our department is one of the largest emergency departments in the entire nation in the US. And we have on average around 150,000 annual visits, averaging around 450 daily visits. But since March 22nd, the number went down to 250 daily visits only. So we were wondering who is no longer coming into our department, and that's our actually main research question. So we obtained data basically comparing what had happened since the beginning of January to April, which is like 18 weeks. And we compare some historical data looking into 2018, 2019, and 2020, because we want to compare what had happened previous year was not the same pattern compared this year. And as you can see, the drop down really took place at around like mid of March. So there's like no coincidence that like this is not something out of the whole COVID-19 pandemic. So we look at the outcome of ED volume, admission rate, ICU rate, and look at a variety of patient demographics and also clinical characteristics that we can obtain from the EMR, electronic medical record. The data is obtained from the LAC USC ORCID data. And then I co-lead this study with Dr. Sarah Axine. And just based on this couple months, we're looking at close to 200,000 patient visits. Next. There are 4 panels in this slide. The first one is looking at the total ED volume. Like A A is looking at the non-respiratory. So you see that like I had a red line there. That red line shows that what happened in March 19, which is like when the California shelter in place order actually took place. You see that compared to 2018, which is the blue, 2019, which is the orange, 2020, there's a huge discontinuity around that period. We have a huge drop in terms of patient volume starting at around week 12, which is like around mid of March. And also looking at panel B, the total ED volume for the respiratory cases. Although you can see that because usually the respiratory cases coming into a department kind of decrease across the winter period into the spring period. But you can also observe that around week 12, there's a huge discontinuity as well. So even though there's a discontinuity, but then it doesn't mean that we are not really seeing more severe respiratory cases, because overall our department volume has been affected, the non-respiratory and also respiratory cases. And for panel C, you look at admission rates. We have slight increase of admission rate for the non-respiratory cases starting around week 12, but specifically, the overall admission rate has been driven by the respiratory cases in panel D. So you can see that there's a huge spike in 2020 in terms of the rate line, in terms of the respiratory cases admission into our department. Next, please. And Dr. Exton will be starting from here.
All right, great. Thanks so much, Jonathan. So what we're showing you in the next couple slides is just sort of the breadth of the data we have in terms of the demographics that we're able to pull out related to these visits, as well as some detail on the severity and the diagnoses that we're talking about. So what we have here is the distribution of ED volume in 2020 by week. And as Jonathan noted, weeks between 11 and 12 are when this shelter-in-place order goes into place. And as you can see, sort of across all demographics, we see fairly sharp discontinuities at that 11 to 12 week period, noting that there is some major impact of the shelter-in-place on sort of the distribution of patients that are showing up to county. I would note that these are all shares, and so what we're showing you is the distribution. Overall, all these numbers are dropping. It's just that some rates are dropping sort of less slowly or more quickly than others. The things that stick out to us are the huge drop off in patients under the age of 18 coming to the emergency department. So basically kids have just stopped showing up to the ED, which is a little bit scary. When we look at it by payer, it looks like the privately insured and Medicaid insured have just left the ED in the weeks sort of immediately after that safer at home declaration. And we've seen an increased utilization of the ED by these people with sort of other public programs, and most notably by the uninsured. We have a way of sort of proxying for undocumented status based on people who should be eligible for Medicaid but are not due to their citizenship status, and it looks like they too sort of dropped off, although much less sharply than other populations, and appear to be one of the few populations that's returning to the ED by the end of April and probably again through May as we get that data. On the race ethnicity side, you'll note that Hispanic populations are plotted on a separate axis just because it's the overwhelming majority of patients seen at county, but they too are sort of rebounding in a similar manner as those undocumented patients, and the African American patients seem to be actually dropping off later rather than right at that safer at home implementation. Next slide. So this is the piece that I think is probably most relevant to this group. If we look at the share of ED visits by selected diagnoses, we've just picked out a couple of really common ED diagnoses. You'll see that across most cases, it's sort of a flat, impact. Obviously, we know in sheer numbers these are dropping, but sort of in terms of their share of all ED visits, it's fairly similar. But what we're seeing is right at that shelter-in-place order, that patients who are coming to the ED with mental health and or substance use disorders are actually sort of increasing as their share of ED volume. So that's the single population where we actually didn't identify one of these very strict drop-offs or no real impact. We're going to dig a little bit more into whether that's mental health or whether that's substance use. Anecdotally, providers are telling us that there are a lot more patients showing up with symptoms of having used methamphetamines. So that's sort of what we're looking at next. So next slide. So as we've sort of talked about briefly, these preliminary trends show an effect of COVID and the shelter-in-place order on the volume of ED visits, admission rates, the patient demographic mix, and the patient diagnosis mix. We're going to focus our future efforts on adding a couple new variables, things like homelessness, the geographic location where these patients are coming from. We want to see if certain communities are being unduly affected and are sort of staying away from county or not. And then looking at this question in sort of the longer term of who's returning to the county ED, when that really starts to happen and for what conditions. We're hoping once we sort of wrap up this preliminary sort of short-term analysis to move on to something like a 6-month or 1-year implications, particularly for this question of patient mix. And if you have any specific questions, particularly about the data, Jonathan is the person to talk to.
Thank you both, Dr. Axine and Dr. Lamb. Next, we have Ms. Elizabeth Shimada.
Hi, everyone. Thank you so much for having me. My name is Elizabeth, and I'm a third-year PhD student in the sociology department. Next slide, please. My project is called In Health in Sickness, How the Coronavirus Outbreak is Affecting Romantic Relationships by Social Class. So as we've seen on the news and we've heard through the cutting edge research being presented here today, the coronavirus outbreak has completely changed the social milieu, including family life. On top of shelter-in-place mandates and school closures, which have caused couples to homeschool their children and be around with their household members 24/7, unemployment rates are skyrocketing, businesses are closing, and essential workers are being put into health hazardous positions. This has further disadvantaged families experiencing economic hardship and caused some families to experience downward economic mobility. So this project will examine how the coronavirus outbreak is affecting romantic relationships across the socioeconomic spectrum. It asks, how does this pandemic differentially affect couples' lives along pre-existing social class lines, and how has it changed experiences for couples, previously more affluent couples, experiencing new economic precarity? To answer these questions, I'll be conducting in-depth interviews with 50 couples across the SAS spectrum over Zoom or via phone if internet connection is not available, for a grand total. So I'll be interviewing doing one interview per partner for a total of 100 interviews to find out how their lives as a couple have changed since the coronavirus outbreak. I'll be using the constant comparative method to analyze my data, so I'll be making decisions about theoretical casing as I'm collecting the interviews, but here are my 2 main lines of inquiry as I'm starting the project. First, oh, sorry. You could go to the next one, sorry. Thank you. First, technology and rationalization affects people's relationships differently based on axes of inequality. So sociological theory and empirical work on the effects of the internet and social media on relationships is mixed, with some saying that it provides an increased pool of potential partners and more ways to reach out and stay in touch with them, while other theorists say that these technologies have individualized romance and introduced dating market logic into dating, where potential partners are replaceable, romantic love is linked with economic consumption, and compared to real life interactions, these technologies give us the illusion of intimacy. But what I'd like to explore further is how inequality fits into these theories, and this pandemic is a unique time to do that. So I want to know, what are the implications of being forced to use technology to maintain your relationship, or to focus, or to maintain your romantic ties with literally everyone else while being sheltered in place with your partner 24/7? And how do different levels of access to these technologies on top of economic precarity affect couples' experiences? And this second thought kind of builds onto this. So that the COVID-19 outbreak is further revealing the links between SCS and families' experiences. So we know from decades of social research that structural inequalities disadvantage lower income families in a lot of different ways, in access to job stability, health outcomes, in the legal system, and in education, just to name a few, often along multiple axes of like race and gender. And to navigate these inequalities, lower income couples often have to redefine romantic life, parenting, and understandings of gender in unique ways. And I anticipate that many of these structural disadvantages are at play and complicated even further during this pandemic. And I'm interested in how couples across the SES spectrum are faring and adapting as a result. Next, please. I'd like to sincerely thank USC Center for the Changing Family for allowing me to do this research, and thank you so much for having me.
Thank you. We appreciate it. We're moving right along to Dr. Beth Smith.
Thank you. I'm very happy to share our survey with you today. My primary research interest is in infant development. Next slide. And we have a 20-minute survey to assess the experiences and feelings of pregnant women and new mothers with infants under 6 months of age during the COVID-19 pandemic. So our survey is associated with the CoGen Research Alliance, which I'll come back to briefly at the end. We have a number of general questions about demographics, financial concerns. We also have a number of specific questions related to birth plans, changes in birth plans, questions like that. Oh, next slide. And our survey method, we are using Facebook ads, Craigslist, and emailing related blogs, things like that to recruit participants. We have, people can remain anonymous, or they can choose to provide their identity to enter a raffle for an Amazon gift card. So we're raffling off a $25 gift card once a month. They also can choose whether or not to submit their contact information for potential follow-up for future studies. So at this point, we have 317 women who have consented. We have 185 complete responses. People can leave the survey and come back to complete it at a later time. It takes about 20 minutes, but my understanding is this is pretty expected for survey research. We have 142 women who have said yes to follow-up. And one of the things that I'm interested in at this point is that our survey is 83% of the respondents are not of Hispanic, Latino, or Spanish origin, which is not representative of the Los Angeles area. And I think it's a combination of where we're recruiting and also that we do not have a Spanish language option at this point. We have the survey translated into Spanish as well as the consent documents, but I have concerns that it's not culturally sensitive, and I don't want to just translate something and launch it out there without having appropriate resources and team members to help us do it correctly. So that's one of the things that I'm interested in if anyone out there is interested in joining the team. We currently have my PhD student, Judy, is on the team in biokinesiology and physical therapy, another faculty member, Kate Havens, and then Bobby Pineda in occupational science and occupational therapy. And we'd like to thank the Center for the Changing Families Small Grant Program for funding. Next slide. And here briefly is a screenshot of the CoGen Research Alliance. You can see the hub sites listed. So Los Angeles, we're one of the hub sites. This is a global network, and the idea is that researchers across the globe will be collecting data using the same survey. We can choose to compile de-identified data as we analyze it, or we can choose to do it on our own. We're not required to participate, but it's an interesting opportunity. There's an open science framework website, so there are resources there for the survey, for a bunch of other measures. And as I said, I'm interested in expanding our work to capture a representative sample in the Los Angeles area. And also, we plan to do future projects with our cohort once we're able to get back to some human subjects research. So thank you, and I'm happy to answer questions.
Thank you, Dr. Smith. Next, we have Dr. Jeffrey Sugar. Just working on getting unmuted. Give us a second.
Yeah. I think it's unmuted now.
Yeah, it's perfect.
I'll say, okay, good morning. Next slide, please. So I think we missed the title. At least, okay. No, one slide back. No. Okay, so all right. Well, let's just go ahead. I think they're a little bit out of the order that I had. So the name of my instrument is Skater, pronounced Skater. That would be a little bit more surprising if you saw how it was spelled. So next slide, please. So the actual title of this talk was to be Beware the Background. And the reason I said beware the background is because whenever we're looking at any kind of stressor, it's really important to understand the background in which that stressor occurred. And as a child psychiatrist who specialized in trauma and working with an indigent population for more than 30 years now, I think it's critically important that we know something about the history of the people who have stressful things happen to them, because that clearly has an effect on how they respond. So SCATR was created to fill the need for a short yet comprehensive screening tool for child trauma and adversity that would be both sensitive, so we wouldn't miss anybody, and specific, so that families wouldn't be assessed, in the words of our pediatric emergency department, wrongfully. And this was something that they were quite concerned about, because we did this, most of our patients were interviewed through Medical Student Power, because it's available, and it's they will do this free. And we were doing this in the pediatric emergency department at County USC. There was great concern that we would just round up a bunch of families and send them to DCFS and have the kids removed. Of course, this didn't happen. That was, I think, an understandable concern from someone who's never really worked with DCFS very closely. So the other requirements were that this could be administered in real-world clinical settings and in a format both for caregivers and children, in English and in Spanish. Next slide, please. So as I said, we wanted something short, comprehensive, sensitive, and specific, kind of a tall order. And early on in this process, I discovered that the sequence was important. In fact, it was the sequencing of how these questions were asked that led me to develop this in the first place. For about 6 years, I ran our child crisis and consult psychiatric service. And I had the repeated experience of good trainees coming and telling me that a child had not experienced any kind of adversity, specifically sexual or physical abuse. But I would talk to the child for a few minutes and find out that indeed they had. And I discovered that it's really important how you ask the questions, very specific words you use. If you ask a child about abuse, they may not know what you're talking about. And if you don't enter into it relatively, develop some degree of rapport before you start asking these questions, they're just not going to tell you anything, because many adults as well as children are filled with shame if they've had these things happen to them. So we begin with the questions about safety and attachment, and then end with more positive experiences. And we always give everybody the option to explicitly not answer by just circling pass. Next slide. So through some trial and error, my colleague, Julian Ford, the developer of the Traumatic Experiences Screening Inventory for Children and a senior trauma researcher at the University of Connecticut, he and I developed this two-step process where we would begin with a paper questionnaire, and these are just samples of the 30 questions. So number 17, which was one of the most difficult questions to get the wording exactly right. Did anyone ever touch or do things to your private parts in a wrong or bad way? Options are no, yes, and pass, or touch or do things to your private parts and ask you not to tell anyone. Again, no, yes, and pass. So the instructions are for the administrator, the person who is actually handing out these papers, and then following up to follow up any question that's answered in a way that's affirmative for adversity or trauma. And that's a mix between yes and no. So for number 17, the trained administrator would ask, who did this to you and what do they do? And then check all the ages in which it happened from 1 to 18 in a simple scale. Next slide, please. So further, the ED asked us, and I think not unreasonably, well, you find out all these things about the kids, so what? What difference does it make? You know, if it happened to them 10 years ago. Well, we took a cue from the DSM, Diagnostic and Statistical Manual for Mental Disorders, which for the last few iterations has required that before we can call anything a disorder, we have to show that it's caused significant stress or impairment. So, and I think that's a pretty good thing to be asking. It makes sense. So we decided not to look at specific symptoms because there's other good measures of symptoms, but we asked question number 27, after these bad things happened, did you have more problems than before they happened? Again, no, yes, pass, and then circle the kinds of problems. So to get at the kinds of problems, we looked at the domains of experience that children have and decided to ask a whole range, ask where they experienced these more difficult problems. So it could be with parents or family, with friends or other kids, enjoying sports and games, at school, drinking or using drugs, following rules, being around other people, being by yourself, and having fun. We think that pretty well covered the gamut of their experiences. And then have them put a star on any of these things. There was still a problem within the last month. And again, that month cutoff was to be in accord with the DSM, which requires impairment or stress within the last month before you can make a diagnosis. Next slide. So we did a number of trials in the pediatric emergency department. At USC, we had 95% of one sample of 64 pediatric ED patients who didn't have a life-threatening illness. We weren't going to stop someone in the middle of being assessed for a serious medical trauma and ask them these questions. And each interview took less than about 10 minutes. 63% reported at least one adversity, which is pretty low, but 15% reported 4 or more. And as expected, a greater number of types of adversity predicted greater functional impairment in any category and more categories of impairment. Okay, next slide. So in conclusion, our tool SCATER is an efficient and acceptable method to screen for childhood adversity as reported by children and their caregivers, and also as expected, increasing adversity types correlate with impairment. But the final conclusion, I think, is best stated by the New Yorker cartoonist Roz Chast. Next slide. Who asked what it all boils down to? And she shows you there. It boils down to a cup of small, medium, or large. And then I have one final slide. And this is a little different, but I felt like it was important to take advantage of this kind of national natural experiment where we're taking kids out of their usual school classroom and putting them in online education. And I think this might have some serious effects on the construct of connectedness, which is something that's really been used mostly in educational settings, but I think really applies to families and communities just as well. And it's a child's sense of support and belonging within a social system. It's been operationalized in a few survey instruments, but again, mostly the questions as they're asked usually apply to kids in school. So the question is, I would expect that connectedness would mitigate against child depression and anxiety. That hasn't been shown explicitly, but it seems pretty intuitive and logical. But then the more significant question when we're moving kids back and forth from online into, from in-person to online school and potentially then moving them back, and some kids may stay in online education or have some hybrid models, does the mitigation by connectedness vary with in-person versus online versus hybrid educational models? So thank you. I'm talking kind of fast because I thought we had 5 to 8 minutes and I wanted to get it in between 3 to 5. And I'd be happy to take questions later.
You did a great job. Thank you, Dr. Sugar. We have Dr. Cermak.
Next.
Your turn.
Okay, so go back one. Okay, I'm interested in doing a time use and social networking study looking at college students and the impact on their mental health. Next. Basically, the purpose is to examine and document how college students are spending their time and the relationship of their time use with their social networking and their perceptions of occupational balance and mental health. And we're going to be examining factors that relate to psychological distress. Our procedures will involve online questionnaires, and for those who agree, virtual interviews. Next. So the phases that we're involved in is right now we're involved in developing the protocol and applying for an IRB. We will be conducting a pilot and feasibility study this summer with a small number of students, and we're going to be involving our DIA Jumpstart students in this process. DIA stands for Diversity, Inclusion, and Accessibility, and this is a program designed to facilitate or foster underrepresented students into PhD programs and have them become research scientists. So they typically, these students spend time in a research lab. I had 2 students last year, and with an active research program at Children's Hospital, that has certainly been stopped because we're not able to see clients. So we're shifting over to this, involving them in this time use study, which is a core concept of occupational science and occupational therapy. We're second phase will be developing and submitting a proposal for a larger scale study, particularly for funding, conducting the study, and then our last phase will be, I can't tell because people's pictures are all over it. Is there a way to move that? Yep, but there is. Okay, we'll be using the information to work with mental health care providers at USC, including the Chan OT practice, the Cortex Center, and other programs to develop and disseminate informational materials and targeted interventions that would reduce stress and enhance occupational balance in college students, and that this materials would be available to beyond USC. It would be available to other programs that are dealing with this population. We are specifically looking at undergraduates, and we're looking at people in their sophomore, junior, and senior year, because we want to get people whose schooling was disrupted from COVID while they were already attending the university in a typical fashion. So we're not including freshmen. Next. That's it.
Awesome. Thank you so much.
Thank you.
We have our last presentation, Dr. Judith Perigo.
Hi, thank you for having me. Can we move on to the next slide, please? So I am currently in a no man's land, meaning that last week I graduated from the PhD program at the Susan Peck School of Social Work. And in July, I began as an assistant professor at the UCLA Luskin School of Public Affairs. So for now, you'll see that I'll share my personal email if you have any questions at the end of this presentation. So my project is entitled, sorry if you could go back one, yes, Education-Related Parental Involvement During the COVID-19 Pandemic. And specifically, I'm interested in understanding how low SES families are coping. Next slide. So the data comes from a collaboration between USC, the University of Chicago, and Harvard. It is the Czech Heights Early Childhood Center study, or CHEC. CHEC is a randomized controlled trial study that was implemented from 2010 to 2014, and it's a longitudinal study, so the researchers have continued to follow over 2,000 households. The principal investigator is Dr. Anya Samek. She is here at USC at the Department of Economics. And I got involved with CHEC as part of my dissertation, which I began last year in 2019. And with funding from the USC Center for the Changing Family, I was able to expand my dissertation to look at some COVID-related questions. Next slide, please. So I'll briefly summarize my dissertation activity, which was a 3-phase explanatory sequential mixed methods study. In the first phase, I used longitudinal growth curve models to look at academic achievement trajectories from preschool to 3rd grade. And so I'll just highlight 3 lines here. At the very top, the blue line, these are children that were above average when they began school in preschool, and at the end of 3rd grade, they continue to be above average. So these children are proficient. And at the very bottom are children who started off below average and continue to be below average at the end of 3rd grade. So we label these children continuous risk. Now, the one that I'm the most interested in is the green line, which are children who effectively close the academic achievement gap. They start off below average, but by the end of the 3rd grade, they are above average. So that was the first phase. In the second and third phase, I conducted qualitative focus groups, 10 of those, and 23 individual interviews. And they were divided into the groups stratified by the academic trajectory groups that were determined in this first phase. Next slide, please. And so what I found in my dissertation are there are significant barriers to parental involvement in terms of young children's education-related activities. Some of those barriers include language, parental education, cultural expectations of what the parents should be doing and what schools or teachers should be doing, as well as time and resource constraints. So now with the recent closures of schools and the stay-at-home orders that have been initiated by COVID-19 pandemic, it is very likely that it's exacerbating these pre-existing parental involvement challenges and disparities, especially for low SES families. Next slide, please. And what I mean by low SES families, in the Czech study, 2/3 of their families have an annual household income of less than $36,000. A little over 19% of parents did not have a high school diploma. A little over 30% of parents were unemployed. And again, this is all pre-COVID data. And several households were recipients of federal aid, such as Medicaid, food stamps, and WIC. Next slide. So I went back to these families and conducted interviews to understand how are they coping with this recent transition to now becoming their child's primary educator. Also to identify how pre-existing barriers and facilitators related to their children's education is affecting them, as well as understanding how parents identify and navigate this education-related resources. We just completed data collection yesterday. We had 79% response rate, and we have talked with 31 parents. Next slide, please. So these are preliminary findings. I'm a little hesitant to really call them findings because we have not yet analyzed the data, but I did want to share some of the kinds of things that we're hearing from families. And these four are ones that I wanted to highlight. First is that children are doing their school assignments mostly on their own. The parents have lots of different barriers that prevent them from being involved. And so the children are really working on their school assignments independently. And while there are some benefits, there are also some challenges with that. The second is that parents are describing their children as struggling to cope with the pandemic more than the parents themselves. The way the parents describe this is that the children are sad because of reduced food availability, but also lack of connectedness. They're missing their peers and the in-person socialization. Also, parents report that their children are struggling with anxiety, which is related to added pressure of completing independent schoolwork. The third is that families are eating less. A lot of the parents reported that they are specifically eating less meat. Sometimes that is because there isn't meat available in the grocery stores, but also it's a more expensive item. So parents are reporting increasing intake of rice and beans and vegetables to compensate for other groceries and foods that they are unable to get at this time. And the last, in our sample, there are several families who are immigrants. And when we ask them how they are feeling about, remaining at home and with the stay-at-home orders, one mother very kind of interestingly said that she feels like she has been quarantined in her house before the pandemic because of her undocumented status. And so she really feels like not much has changed, which was a different perspective. So next slide. Okay, so that was the last one. So thank you. And again, if you have any questions or comments, we'd love to hear from you.
Great, thank you so much. You rounded out a fantastic lineup of presentations. I appreciate that. And congratulations on your PhD. It's exciting.
Yeah.
Give her all a round of applause. And finding a job during this time, that's impressive as well too. So we have a few questions from the audience. I'll be looking for some more, and a lot of them are directed just to the panelists in general. So I'm going to ask you all to kind of raise your hand or just unmute yourself and begin to answer a question if you think that you might be the right person to answer. Here's one question. What are the key concerns for adolescents and young adults for children in this pandemic? Key concerns for that population group. We had, about 4 presentations about this population. If you could boil it down.
I can go first. My study or questionnaire was more general. It wasn't specific issues. So we asked questions like, do you feel stressed, anxious, etc.? Or do you feel down, sad, or depressed? Do you have enough emotional support during this time? So we didn't look at specific issues as much as their overall general feelings.
Thank you. We know a lot has changed. Go ahead.
Sorry.
Please go ahead, Dr. Cermak.
Excuse me?
Oh, please go ahead.
That was Darby.
That was me.
Oh, hi.
I was going to say I can take a stab at this. I think in terms of key concerns, I think there are sort of 3 big domains. One is just the loss of social connection, and I think that affects children differently at sort of different places along the age range. I think for preschoolers and young kids, there's just the opportunity for a lot of social emotional learning to take place that they're being deprived of. So much of preschool is just about learning to share and sort of, form one's first friendships. And then I think on the other end of the age scale in childhood for teenagers, there's just absolutely massive disruption to their ability to see their peers.
which I think is really devastating to a lot of teens. So I think social connection is one big domain. Another big domain is schooling, both sort of the structure of the school day and then the content and the material that kids aren't getting to learn, and the frustration of parents trying to manage the school day. And I think another big domain is just sort of anxiety, sadness, existential dread, just the fact that we're living in the midst of this massive disruption. They're seeing their parents potentially out of work. They're afraid of getting sick. So I think things kind of fall into those three areas, but there's just a ton going on for kids and families right now.
That's a great answer. Dr. Sugar.
Yeah, I mean, I think as my presentation indicated, I think it'd be really important also to say, how were things before this all started? Because for many kids, this is as horrible as it is. It may not be among the more serious things that they've been concerned about.
Thank you.
Yeah, and I'll also add, I think there are some potential upsides for kids and families. The extra sleep that a lot of kids and teens are getting is potentially beneficial. Having extra time at home. I do think there's a lot of disparity in terms of who's able to benefit from some of those upsides. And that's why it's so important to look at socioeconomic differences in families' experiences.
Yeah, I would like to just add to that. We also in our survey, our very last question is asking what are some of the benefits or positives that have come out of the pandemic. And lots of families are reporting feeling a little bit better in terms of their sleeping habits, also eating healthier, as well as having more time to be with their immediate family, which is opportunities that they probably didn't have before. So there are certainly some positives.
Yeah, and I just want to mention, and great talks. Thank you, everyone. I think one group that probably is getting overlooked is young adults. I mean, and we had one, I think Sharon's presentation was about college students, and so a lot of us are thinking about, so the ones who are on a great track and they're on their way to USC and they're going to be freshmen, or some other four-year college, it's just total disruption. And then you have other folks who, aren't headed to a four-year college. Maybe they're headed to community college, or maybe they're out into the working world and have been for a couple years. This is the group that has the least amount of stability because they're unlikely to have salaried positions, and these are the people who are losing their jobs. They're getting economic hardship, and then also young adulthood is the time where we see the highest levels of substance use and other types of patterns set in that can extend throughout middle and older adulthood and actually end people's lives earlier. So, that's another group I'm really concerned about in terms of the biopsychosocial pieces of this whole pandemic. And, maybe if we do this again, we'll be able to present some of our work because we've been tracking cohorts of young adults, Dr. Unger and I and some other folks in the Institute. And we're surveying them now. We've been surveying them for years since they were age 14. And so we're going to be able to track if their substance use changes, and kind of how they're feeling about the pandemic. And I haven't seen a whole bunch yet. And so it's good to see that, some of the researchers here and others kind of focusing on the broad range from, really young children through, I guess, when the brain stops forming, right? When you're in your mid to late 20s.
Dr. Sugar.
Yeah, just quickly, could we possibly get back to gallery view? I don't know if it's the same for everybody, but all I can see is a white screen saying roundtable discussion. It'd be nice to see who's speaking.
Sure, let me just stop the share.
And then I also, I had just a brief comment about, things that are different now. I supervise our clinic child psychiatry fellows, and for many of them, having proximity to the family is not the good thing. Some of the kids who have been targeted by, with various kinds of emotional abuse in their families, they're now, living with this all the time instead of just occasionally. And it's a very stressful situation for some kids.
Thank you, Dr. Sugar. on both points. We had a new question just come in right now. For those families who are reporting food insecurity, are any resources being offered to participate based on need and when the need is identified? I imagine there are.
Yes, for the qualitative interviews that we conducted, before we began to conduct those interviews, we made sure we put together a resource list, because we imagined as we asked questions about resources that they did or didn't have available, we wanted to make sure that we made those available if they were in need. And so for the families in our study that have reported a decrease in access to food, we have connected them with local food banks as well as with the school district that is providing food services for the children.
Thank you. We have another question here. The theme was interpersonal relationships today, and we have a question about interpartner violence and how that's a major concern. And is there a concern that in the pandemic about the nonviolent expressions of relationship strain between couples, whether that's a concern or if it's being studied? Yes, Dr. Margolin.
Yeah. So that's very much front and center to the study that we're doing. I mean, you know, the expression of aggression and the way people deal with conflict is really a continuum, with some couples using physical aggression, but usually those couples also are using emotional and verbal types of aggression, and the emotional and verbal types of aggression are much more common. I mean, it should be known, just to give you some perspective, that in general, 1 out of 6 couples have some experience of physical aggression at some time in their relationship. So it's, even physical aggression is really quite common, but nowhere nearly as common as emotional types of aggression. And in our study, and I didn't go into any of the specific questions, we asked very detailed questions, because if you just ask couples, you know, are they aggressive with one another, they'll generally say no. If you ask something like, do you push, grab, and shove, more people will say yes. If you say, do you criticize your partner in front of other people, or do you call your partner names or swear at your partner, you'll get more people. So the question is, you know, is this happening more? If we had longitudinal data, we would really be able to answer that well. But we will be relying somewhat on retrospective reports about couples' experiences if they think it's happening more. And the question that we're really trying to address is which couples are more vulnerable to resorting to those types of destructive communications.
Thank you.
So I just need to jump in and say thank you. I need to prepare to teach here, but if anyone has any questions or wants to catch up, please email me.
Thank you, Dr. Smith. It was a pleasure to meet you. We have a question about health disparities and inequities. So what are the biggest concerns about the impact of the pandemic on inequity and health disparities, including people with substance use and mental health disorders? Who wants to tackle that one?
I'm assuming that's directed somewhat at our study of sort of ED demographics. We're looking at sort of separating broadly into mental health and substance use. Unfortunately, we do start to run into some small numbers pretty quickly when we want to look at things like weekly trends. It looks like the sort of mental health and substance use utilization is centered on individuals who are coming in and being diagnosed with schizophrenic or other psychotic disorders rather than substance use more broadly. We're hoping in the future, either if we can add data from the other county hospital systems, or if we can look at sort of a longer time frame to explore some of these interaction effects between diagnosis and demographics and things of that sort. But at this point, just because of small numbers, we're a little bit constrained to sort of looking at them separately. It may be the case that with Hispanic patients, we have enough that we could do that, but we haven't looked at that specifically yet.
Thank you, Dr. Axine. Dr. Sugar.
Yeah, it's a good question. And I would just also caution people when they're thinking about the construct of SES to be aware that it's a very large kind of composite question. And it would be important to break it apart because SES is itself associated with a lot of other variables, including a greater risk for having adversity. Not surprisingly, you know, if you start off with a lack of resources, it's much harder to manage when something adverse comes up. So, but not everybody who is in a particular SES class has the same degree of adversity and trauma. So those things really have an effect on what happens later and intercurrent things. So, you know, you wouldn't want to mix those up.
Thank you. We have a tough question here for all the panelists. What are your thoughts on school kids returning versus staying online in terms of social connectivity versus the risk to that group?
I mean, I can comment as a parent.
Please.
In the midst of it, you know, it's kind of there, and you know, it's going to vary obviously across age group again. You know, I have two small kids, under 8 years and under, but it's just kind of like one of those things you just look at and like both ways stink, you know, like what do you want your kids to be exposed and like to like exacerbate the pandemic? Obviously not, right? So, you know, and then having them here, one of the things that I'm seeing with, and sorry to be like, this is like so non-scientific, my own N of one, right? It's just the lack of stimulation that the kids get. And, you know, how much, especially in the past few weeks or the last month, just my younger one wanting more attention because not being around all of her kids, all the other kids and teachers. And so not getting stimulation that way. And anyway, I think that, you know, it's as a public health priority, I applaud, you know, like the Cal State system, for instance, and obviously LAUSD for trying to make sure to, I think it's the right move, in my opinion, to keep people at home. I think that just given the situation, though, like impact on mental health and probably metabolic health too, trying to get youth to be active. And we had a presenter last time, Dr. Genevieve Dunn, who's collecting data about this. But I think it's tough, you know, especially for these elementary school kids who have these planned recesses and to get them active. So anyway, I'll let the experts talk.
Dr. Sugar.
Yeah, well,
And Dr. Saxby.
This is a little bit anecdotal too, but I happen to be married to a principal in one of the LAUSD inner city schools in the Adams district. And, you know, for many of the kids that she's worked with, the school is really a source of stimulation. It's a source, it's literally where they get fed. It's where they interact with each other. And home is not the warm, fuzzy place that many of us have. So I think it's going to really vary depending on where people live and what resources are available to them. You know, these kids, their parents often need to work, and so it's hugely stressful to have the kids home, and many of them have not even, the families haven't even shown up to pick up their free iPads given out by LAUSD. So it's really a very mixed bag, and in the low performing schools, I think the kids are really being hurt hard.
Thank you. Dr. Saxby.
Yeah, I completely concur with that. And I also like have my kids running around and making noise right behind me. So I am interested in school reopening so that they can get that stimulation in school. I also think it's really important to think about the economic impact of school and childcare closures. You know, it's been interesting to me that a lot of the reopening conversation has focused on tattoo parlors and hair salons, but in fact, like so many workers are working parents, and without a solution for figuring out childcare, then I think there's just going to be a massive damper on any kind of economic reopening effort. So I've been really following the reopening of schools in France, and they have, you know, developed some systems for spacing kids apart, for making classes smaller, for sort of doing half days and having time to sanitize. I think it's a huge question mark how well it's going to work, but it is something that I think a lot of resources need to be invested into figuring out. Schools, as Dr. Sugar pointed out, really do have this leveling impact in terms of disparity. You know, every kid can go to school regardless of the home environment that they're coming from. And I really am worried about the kids who are falling behind because parents don't have the bandwidth to kind of maintain the rigorous homeschooling demands. So that's my 2 cents.
Appreciate that. Anyone else have a thought?
I have a question, actually.
Yes, sir.
This is Ruben Flores, and I'm a biochemist. I'm not a behavioral psychologist. Fascinated by the subject. I have a 20-year-old who's going to Berkeley and staying home, not doing remote learning, and a senior who's about to go to college. That's a whole new, you know, area of individuals that we need to be thinking about. But I was just wondering if there has been any other time in recent history where we can draw some knowledge or expertise from. The only thing that occurs to me is, of course, the pandemic in 1918. And I wonder if there are any studies that, maybe I missed it in the last session, but there are any studies that can point us in or give us some hints as to, you know, how different populations, groups will react to, you know, the isolation and the barriers that we are imposing on them right now.
This is Sharon Cermak. I know that there have been a number of studies that have come out of China already that have looked at the effects of COVID on mental health of different individuals, different groups of individuals. There's also a number of studies about SARS and the effects of SARS. So that literature does exist, and I'd be happy to share it with you if you wanted to email me.
I will. Thank you. I appreciate it.
Okay, sure.
I know I don't have an answer to that. Great question. Does anyone else? We have 1 minute left.
Well, just in terms of the question of whether we've been here before, you know, I was just talking to someone who had been listening to a podcast about polio and the extent to which kids were kept inside for entire summers. You know, I think we've been living in this kind of blissful age in which infectious diseases have been largely contained by vaccination. So this is a very new frontier for us. But, you know, we've certainly, previous generations, I think, have coped with these kinds of mass disruptions. So it's a fascinating natural experiment to see how we adapt. I think the one upside in terms of thinking about schools is kids do seem to be somewhat more resilient to the virus, and there's some evidence that the mass spreading events that have been documented, kids seem to be less likely to be asymptomatic super spreaders. So that's really encouraging, but I think there's just so much more we need to know before we all feel comfortable reopening on such a broad scale.
I was a child during the polio epidemic, and I really remember it. I remember really being scared that I was going to get it. And we didn't go to public beaches. We didn't go to pools. And it sticks in my memory very clearly. I don't know how old I was at that time, but it does stay with me.
Wow.
Mm-hmm. Yeah, my grandmother had TB and had to go to was isolated for 2 years in the middle of Nebraska when she was 26. So, wow. But thank you all the panelists for their excellent presentations today. I appreciate the time you put into crafting the content and working on this important issue of COVID-19 related research here at USC. I look forward to collaborating with all of you in the future, making connections. I'll be sending an email out with the recording of this, the slide deck, as well as the resources that I mentioned previously in the Google Drive. Looking forward to perhaps meeting again. And yeah, thank you again. Adam, do you want to say anything, or Darby?
No.
Okay. Thank you so much for your hard work putting this together, and thanks for including us.
Absolutely.
A lot of fun. Thanks.
Yes, okay.
Okay. See you guys later. Thank you for the wonderful talks.
Thank you.
Thank you, everyone.
To our audience.